All right. All right. So everyone able to see the slides? Is that okay? All right. So welcome to everyone. Welcome to COVID-19 and implications for the LGBTQ plus community. My name is Chris Surface. I'm a PhD candidate in public administration at Western Michigan University's School of Public Affairs and Administration. I am the president of the first openly gay elected president of ASPA Michigan Capital Area Chapter. I have worked with two of our panelists before. This is my first time working with Natasha, Dr. Bagdasarian. I've worked with Dr. Wally Swan and Paula Overby and the Rutledge Handbook of LGBTQIA Administration and Policy. So far, I'm published in 3 works on LGBTQ+, the Flint water crisis, and then also I've presented at about 12 conferences around the country, and I'll be doing my first international conference in July at the International Public Policy Association conference in Barcelona, Spain. So we're going to go ahead and get started. We have 3 other panelists, Dr. Wally Swan, Dr. Natasha Bagdasarian, and Paula Overby. The order of the speakers I will present first, then we'll go to Dr. Bagdasarian, then Dr. Swan, and then we'll end with Paula Overby. So the goal of the panel, we want you to understand how to identify the disparities facing the LGBTQ plus community on COVID-19 and to be able to apply this knowledge to various administrative and policy concerns. Policy challenges. The LGBTQ plus community was attacked over 70 times by the Trump administration in terms of policies, rights, and benefits. The Human Rights Campaign maintains a list of this, and Dr. Wally Swan has devoted a substantial effort in identifying various instances. In Michigan, the Elliott Larson Civil Rights Act of 1976 has not been updated yet to include sexual orientation and gender identity protections in housing, employment, and public accommodations. The Bostock decision by the U.S. Supreme Court has allowed for employment discrimination to be tried in court as sex discrimination under the Civil Rights Act of 1964. There has not been an interpretation extending this to housing and public accommodations, as the cases in the Supreme Court were narrowly related to employment discrimination. The LGBTQ plus community faces disparities and marginalization in healthcare access to services, including HIV/AIDS and PrEP for prevention, and then healthcare provider discrimination. There was a lack of marriage rights until 2015, until the Obergefell decision legalized same-sex marriage in all 50 states. Employment discrimination until Bostock in 2020. There's still challenges at the state and local levels. A lot of patchwork of policies. You may go from one community, like in the community that I'm from, Grand Rapids has LGBTQ plus protections, but when you go across the city boundary into Wyoming or Kentwood, Michigan, you don't have those protections. And you don't have those protections for the LGBTQ community at the county level. So that's just one of an example of one of the ways in terms of non-discrimination policy. And then, housing and public accommodations discrimination, hate crimes, and then mental health, suicide, substance abuse, alcoholism, and tobacco. And then there's social discrimination in religious institutions among peers. Social isolation leads to non-compliance of social distancing and risky sexual behaviors, citing McKay et al. 2020, Green 2021, and Human Rights Campaign 2021. HRC President Alfonso David said that 1 in 5 LGBTQ plus live in poverty. 1 out of 5 lack health care insurance. LGBTQ plus employed in the service industry at a significant rate in terms of the overall occupation identification. The gap is greater for people of color and transgender people, and LGBTQ plus more likely to follow public health guidelines. And this kind of comes from the political identification of the LGBTQ plus community. The majority of LGBTQ plus are Democrats or more progressive. So unfortunately, given the past year or so, the in terms of compliance with public health guidelines like masking, distancing, it's become a partisan issue, and it shouldn't have been a partisan issue. So LGBTQ plus are more likely to follow these public health guidelines, but face disparities due to health conditions like HIV/AIDS. And then also there's some research on hypermasculinity in general, and then internalized hypermasculinity in the LGBTQ plus community, leading to higher COVID-19 cases and hospitalizations. And then the LGBTQ plus community is poorer than heterosexual and cisgender. The rate of poverty is 37.5% higher among LGBTQ plus. The Human Rights Campaign estimates that approximately 15% of LGBTQ plus work in restaurants and 7.5% work in healthcare settings. So this particularly in terms of occupation poses some risks to COVID-19 transmission cases. And then, of course, there's a history of public sector discrimination known as the Lavender Scare. Basically, in the 1950s and 1960s, in the era of the Mattachine Society, and you had the Red Scare with McCarthyism, and became the Lavender Scare, in which LGBTQ plus were targeted in social places and occupations. And this has created a number of issues, in particular for LGBTQ plus elders. So substance abuse concerns, this has been a problem in the LGBTQ plus community. Essentially anything that would raise blood pressure would cause you to be at a higher risk for a severe case of COVID-19 and hospitalization. Breakdown of the patient-physician relationship and a lack of blood pressure medication management. And then there's a history of recreational drug use like cocaine, amphetamines, amyl nitrates or poppers, and other drugs that contribute to cardiovascular disease. HIV/AIDS could lead to a more severe COVID-19 case. Research currently is mixed on whether Truvada and Descovy for pre-exposure prophylaxis prevention and treatment provide additional benefits in fighting COVID-19. It is believed that these drugs strengthen your immune system, and that can help ward off a more severe type of infection that would lead to hospitalization. Homelessness among youth and discrimination in housing. It's also magnified for people of color and the transgender community. There's a higher percentage of people that are homeless because there's a lack of distancing and a lot of homeless shelters. And I know in Grand Rapids there was an encampment, and the city of Grand Rapids cleared out the encampment and created a makeshift shelter for those that are homeless. So the homelessness issue is big in terms of stopping the spread. And then also LGBTQ plus elders are often alone and in nursing homes due to fear and trust issues of being out due to challenges that the older generation faced in times past, with the lavender scare. Transgender elders have higher rates of sexual assault and violence, data invisibility in research, and face higher rates of family rejection and isolation than the rest of the LGBTQ plus community. Tobacco and health conditions, LGBTQ plus are 37% of LGBTQ plus adults smoke every day compared to 27% of non-LGBTQ people. Asthma, 21% of LGBTQ adults have asthma compared to 14% of non-LGBTQ people. Recommendations include reading the Rutledge Handbook of LGBTQIA Administration and Policy to enhance your information on various policy issues impacting LGBTQ plus community. LGBTQ plus should quit smoking and check their blood pressure and ask their doctor about an ACE inhibitor like lisinopril or Zestril. The research on ACE inhibitors shows that those who take drugs like lisinopril are less likely to be hospitalized due to COVID-19. And then some of the basics: wear a mask that fits good, or wear 2 masks like I do. Maintain a social distance of 6 to 12 feet. Wash your hands for a minimum of 20 seconds several times a day. And try to use cleaners with a minimum of 60% alcohol. And then this is some of the references that I used in this presentation. Our next speaker is Dr. Bagdasarian.
Thank you so much. I'm very pleased to be here today. And let me just share my slides.
I just passed the presenter privileges to you.
Okay, thank you. Let me try again. Okay, great. I think it's working. Can you see my slides okay?
Yes.
Great, thank you. So my name is Dr. Natasha Bagdasarian. I'm an infectious disease physician, and I did all of my training here in Michigan, and then went overseas and worked in infectious diseases and hospital infection control for a few years. And now I am back working with the Michigan Department of Health and Human Services on the COVID response, specifically on testing, but on all aspects of COVID. So I'm very happy to be here with this group today and to be talking about this very important subject. My talk will mostly be on just the general response to COVID in the state. And then I'm really hoping that some of my fellow presenters can bring this all back to some of the main issues for the LGBTQ community in their talks after mine. So I'll talk a little bit about the general COVID response in Michigan. So our guiding principle has really been to prioritize case detection and vaccinations to protect vulnerable populations. So that's what our goal has been at the state level. And how do we define vulnerable populations? We really talk about congregate settings. So that's places where there's a high density of people and there's a lot of potential for transmission to occur. So places like nursing homes, prisons and jails, and agricultural settings, so migrant worker camps. Those who are elderly and have comorbidities, and then socially vulnerable populations. And these are the places where we've tried to make sure that testing is available and vaccines are available. Social vulnerability, we've used as a way to over-allocate some resources, so testing and vaccine resources. And social vulnerability is defined as communities who may have some adverse outcomes based on socioeconomic status, family composition and disability, minority status and language minority, housing type, and transportation. So we want to make sure that no one is excluded from having a good outcome during this really difficult time if they fall into any of these categories. So I'll talk a little bit about the epidemiology here, and I'll show you some statewide trends. Generally, the story that I would like to paint here for you all is that things are going better in Michigan than they were just a few months ago. So these are some of the metrics that we look at closely. We've got percent positivity. So that's really how many people are testing positive out of everyone we're testing, and it's a sign that testing is robust. So testing positivity is down at 3.5%, which is good. Daily cases per million are also down. We're at 94.7, which is better. We're still not where we were last summer, and we'd like to get back there in the late summer and fall, but definitely better than where we were in November. And our hospitalization rate is going down. So that tells us that our health systems are not overwhelmed at the moment. This is our positivity by county, and you can see what the whole state looks like. And what you'll see is that most places in the state are the same shades of blue, which again is good. It shows that there's not too much variation or heterogeneity. We would like things to be fairly standard, meaning that we're meeting the needs of people no matter where they live in the state. This is a look at age group with daily new cases. And you can see a couple of trends here. So number one, the highest cases have been in those aged 30 to 49. At some points in the pandemic, younger people have really faced a higher burden of disease, maybe because they're more mobile, maybe taking more, engaged in more riskier activities with large gatherings and things like that, where they could be exposed to COVID. And our younger age group seems to have declined a little bit more slowly than the other age groups. Here you can see one of the trends with this look at age group is our very youngest members of society, so those in the 0 to 9 group, have the lowest case rates of COVID. And that's one of the reasons why we feel that schools are relatively safe right now. However, there have been decreases in COVID case rates among all these age populations. When we look at COVID by race and ethnicity, you can see that there have been some trends here that have changed over the course of the pandemic. So early on, back in March, African-American populations were really adversely affected by COVID-19. And now that has shifted a little bit. And so you can see that African-American daily new cases has come down and is in line with those of other races. We still have more cases when we look at those who are Hispanic or Latino. So they're still disproportionately affected by this pandemic. When we look at where we're having outbreaks, throughout the pandemic, we've seen that assisted living, nursing facilities, and other long-term care facilities have been disproportionately affected with outbreaks, and far surpass our second area of outbreaks, which have been schools. In general, we think that schools, I described them as safe before. Many of the outbreaks that fall into the school category, it's not from transmission actually occurring in school, which tend to be safe places where people wear masks and distance, but actually from occurring with social gatherings outside of school. When we look at deaths, one of the things that is not surprising to any of you on this call is that deaths have been much higher for those in older age groups. So only 10% of deaths have been in those below the age of 60. So those who've been most impacted with higher mortality have been over the age of 60. And you can see the mortality rate in those over the age of 80 is very high. I won't. Okay, I'll talk about this a little bit. So this is just a breakdown of race and ethnicity, again, looking at mortality. Briefly, I want to mention the new variants. So there are 3 variants of concern that are being transmitted over several states now. The B117 variant is the variant that we have here in Michigan. We do look like we're a very bright blue color up here. And part of the reason for that is we've had a few areas where there's been transmission of the B117 variant, but we've also been doing a lot of sequencing, so more sequencing than other states. So I think we're just aware of our B117 variants more so than others. This is where the variants have been detected throughout the state. So you can see that there have been some clusters of the variant. And the big issue with B117 is that it's more transmissible. So it's easier to pass this, this strain of the COVID-19 virus onto other people. Our goal with the variants are really to slow them down while we're rolling out vaccines. So as much as we can slow down the spread of the variants, we can get that many more doses of vaccine in arms. I'll talk about testing as well. Testing is a huge mechanism and a huge tool to stopping the spread of COVID. And these are the type of metrics that we look at on a regular basis from the testing side of things. So we look at our number of daily tests per million, and our percent positivity that I mentioned is getting better. So our percent positivity in the fall, we were seeing percent positivity as high as 20%. Now we're down to 3%. This is a good thing. And then these are the numbers of tests that we're doing daily over time. And you can see that the numbers of these, or the height of these blue little bars at the top have been increasing, and those are antigen tests. So the state is doing a lot more antigen testing than we had been early on in the pandemic. And the beauty of antigen tests is that the results are available within 15 minutes. And so you can take really rapid action on the ground. In terms of vaccine, we're currently 22nd in the nation for doses administered. And about 15% of those age 16 years and above have had their first dose of vaccine, with over 600,000 people fully vaccinated. So this is cause for some celebration. When we look at vaccination by age, you can see that most of those who've been vaccinated have been in the older age groups, definitely for first dose. Second dose, we're still waiting for those to catch up a little bit. And that's just the way that we've rolled out vaccine, the way that we've targeted different populations. Initially, we were talking about healthcare workers, and that would have been some younger individuals. And now we're targeting those who are 65 years and older. And this is what our vaccination looks like over time. And you can see that the state has really built that vaccine infrastructure, and every week we're giving more doses than the week before. So all very positive things. Our data on race and ethnicity in the vaccine is just coming back right now. And there's a lot of missing data for race and ethnicity, but most of those who receive the vaccine have been white, but 70% have been missing ethnicity information and 43% have been missing race information. So that that piece of information is still lagging behind. And that is all I have for you today. So thank you for letting me share a little bit about Michigan's response to COVID. And I will stop sharing and hand it over to the next presenter. Thank you.
Okay.
Okay, so we're going to have Dr. Wally Swan speak next. I'm going to go ahead and everyone see the presentation.
Yeah. Let's see.
Right.
How do we move it forward? It's with the arrow down below, right?
I'll control the presentation.
Oh, okay. Fine.
Just tell me next slide whenever you need.
All right. I'll just say next. Can you all hear me okay? Everybody fine?
Yes.
The Rutledge Handbook of LGBTQIA, that's queer, intersex, and allies, and asexual. Administration and Policy book was published 2019, and it has some of the very best data in the country on how many LGBT people there are and where they are located and their race and ethnicity and so on. Next. Chris? Okay. Now, in one of the chapters, I started keeping track of the numbers of federal policy attacks upon LGBT policy, starting at the very beginning of the Trump administration. And up through 2018, I documented at least 45 of those kinds of attacks. these weren't minor attacks. They were things like eliminating protection for LGBT people, for contract employees, and $500 billion worth of federal contracts, and eliminating LGBT protection in 33 states. That's almost half the population of the United States. During 2019, I found there have been well over 19 additional federal attacks. And in 2020, the number went down, but they were done just in time to pander to right-wing voters so that they would see that the Trump administration was supporting them. Next. Here's a list of the 2020 attacks. I'm not going to go through them all, but you can see that some of them, for instance, in July, there was a rollback of a rule that protected transgender people from discrimination by homeless shelters and other housing services. There were all kinds of different attacks, attacks on Title IX, reporting sexual violence and harassment, a lot of attacks on foster care, adoptions, and so on. Next. Well, these 72 attacks essentially left the federally guaranteed LGBT rights in ruins. The only things that were left were that President Trump finally declared a Pride Month prior to the election after not doing so for 3 years. He announced it on the same day that he spoke to an anti-gay organization. Then Richard Grinnell, openly gay man, was named acting national security advisor without congressional confirmation. And he was doing that at the same time he was ambassador to Germany. The administration did positively go on record supporting the elimination of the death penalty for LGBT people, but that only applied to like 8 Middle Eastern and African countries. All of the rest of the rights were wiped away with the exception of the ones granted by the U.S. Supreme Court, Obergefell and Bostock. So next. In 2020, of course, the pandemic struck the United States, and the pandemic had devastating effects on our community. So what was the stance of the federal administration in 2020 regarding LGBT people? There was no federal stance. It had all been wiped away. But there were two things that became important to look at. First, there's very little information about how many LGBT people have been afflicted by coronavirus, because only a few states, for example, California and Pennsylvania, count the number of patients who are LGBT. I noticed Minnesota has set up a lottery system in the last couple of weeks for receiving the vaccinations, and on the form, they have included sexual orientation as a category to check. That's the first time I have seen that in Minnesota, and we're getting lots of pushback, of course, from Republicans who can't figure out why you should have that information on there. Secondly, however, many millions of people became unemployed, as about 11 million, and many of the people in low-income jobs, of which our community has many, were laid off. Half of them, or 9.9 million, are still unemployed. So our community has been disproportionately affected in a couple of different areas I'll talk about next. People in food processing and other essential jobs, for instance, transportation, were suddenly exposed to coronavirus because employers wouldn't provide PPE until directly ordered to by state governments. For instance, my partner works as an essential worker in food processing, and I suffered through each of those stages as they finally got them some protection. And I noticed that 4 of the people who were tested for temperature never came back to work. Also, the border between the United States and Canada, as well as Mexico, was closed, which prevented emigration by LGBT people, thereby preventing them from fleeing the United States. And I know there was certainly a lot of talk about that because of the feeling that we were being so federally discriminated against. Next. In April, the Human Rights Campaign released a survey called The Economic Impact of COVID-19 on the LGBTQ Community. HRC President Alfonso David said, "It's unfortunately not surprising to see that our community is facing adverse economic impacts due to COVID-19. And of course, that's because we have lots of people in low-income jobs, and we also had a lot of people that are racial, ethnic, a variety of different minorities. So we're kind of a cross-cutting all different groups in society." Next. The data in this survey showed that 30% of LGBTQ, I'm just going to say LGBT respondents had their work hours reduced compared to 22% of the general population. 20% of LGBT people said their personal finances are much worse off than they were a year ago compared to only 11% of the general population. LGBT people were twice as likely as the general population to think their finances would be worse off a year from now, 10% versus 5%. 42% of LGBT people adjusted their household budgets compared to 30% of the general population. And then you can see the trust levels in the World Health Organization were much higher. The trust in President Trump was dramatically lower. And strong majorities of LGBT people agreed that we should expect much more in terms of the federal government taking action and employees taking action. Now, this is a poll of 1,000 people, adults in the United States. Go to the next slide. A second study was done in July, August of 2020 with much more recent data. That was a sample of 3,454 adults, including 353 LGBT people, with a sampling error of 3.3%. That found that 66% of households had had serious financial problems, and 52% of the LGBT households were having trouble keeping their children's education going. Next. "64% of the households experience employment loss." I'm a good example of that. I was teaching as an adjunct at the university, and suddenly there were no more students for adjuncts to teach. That happened all over the country. I know City University of New York laid off 2,200 adjuncts right at the beginning of this COVID experience. 38% of LGBT households have been unable to get medical care or delayed getting medical care for a serious problem versus 19% of non-LGBT households. Next. What's interesting is that 40% of the LGBT people are concentrated in 5 industries: restaurant and food service, hospitals, K-12 education, colleges and universities, that's me, and retail. Next. Consistent with national trends, though, this new poll also finds Black and Latino households reported even higher levels of serious financial problems. 95% of Black and 70% of Latino respondents indicated that they or someone in their household experienced one or more serious financial problems. More than half, or 54% of Black LGBT people indicated that they or someone in their household had been unable to get medical care. Next. 1 out of 5 of our households reported they weren't getting enough food to eat. 1/4 said they had serious heating or cooling or mold problems. And note that more than half, 56% of LGBT people rent, as opposed to just 1/3 or 34% of non-LGBTQ people. Next. LGBTQ people in the Midwest have been particularly hard, with 82% of the people in our community in Midwest saying they experienced job loss or disruption, compared to 67% Southerners, 62% Westerners, and 38% in the Northeast. Next. Now, I want to mention that we're presenting a panel very shortly for the National Public Administration Society. There is yet another study that has been done by the Williams Institute with a sample size of 12,400 plus people, which is even better because it shows the effects of the second surge on the LGBT community. The findings are relatively similar, and I have those on the slides that I'll be using with the National Public Administration Conference. Next. Sorry, go back one there. I'm sorry, I jumped over one. So we have problems in our community stacked on top of problems. We have geographical problems, we have hunger and housing problems, we have job losses, we have the loss of medical care, we have discrimination against the LGBTQIA community at the federal level, and we have attacks on the community at the state, county, and city level that were certainly enabled by the Trump administration. Next. So it's very lucky for our community that Joe Biden became president. Major LGBTQ organizations have been collecting lists of each of these attacks and preparing a compilation of those issues that need to be turned around by the Biden administration. Each one of these major organizations, our legal one is Lambda Legal, National LGBTQ Task Force, and HRC, had compiled their list of executive orders that need to be turned around, as well as legislative changes required for full equality. So Joe Biden was elected with lots of LGBTQIA assistance. The percentage is actually that 28% of LGBT people voted for Trump, the remainder voted for Biden, the vast majority. Next. And one of the things I've been mentioning to people, hopefully because people might be interested in applying, is what's called the Presidential Appointments Initiative, a talent bank launched during the Clinton administration, where you can apply to the top level federal positions and be helped by the Victory Institute, which is an LGBTQ organization. Their Presidential Appointments Initiative principles are that we should be bold, being intentional, and be strategic. And we have already achieved one of our goals, which was the appointment of an LGBT person to the cabinet, and that's Pete Buttigieg for transportation. Next level is queer women, non-binary, or transgender people to be an ambassador. And we've got one that I know of so far. And we wanted to place 185 people into administrative positions. There are currently 1,200 LGBTQ resumes in the initiative's file. This process of filling these positions will last all the way through the year. So if people want to apply for this, they can go to the Victory Fund, and there's a form on there that you can fill out. And so that's one way we're dealing with the problem of not having enough people being hired. Next. Now, what has President Biden done thus far? HRC created what they call this blueprint for positive change, which is that list of problems that the Trump administration caused. And the president thus far has done the following. He's implemented the Boston versus Clayton County through the federal government, reversed what the Trump administration did with it, which was just to do nothing. But now they've broadened it to include housing, education, credit, community services, block grant, refugee resettlement, and so on. And the Biden administration is working with state attorney generals in 22 states to implement it in the states. But interestingly enough, states that don't have protections are also getting into this. Arizona, Kansas, North Dakota, Nebraska, and Florida. Biden reversed the transgender ban in the military. He addressed racial, environmental, and underserved communities in the cabinet. And we're anticipating changes in global policy so that we'll be reaching out throughout the world, emphasizing LGBT rights. Next. And we're about to see a step forward. All states currently allow for marriage, of course. All states were granted workplace protection. However, other human rights were not protected since Trump eliminated the Obama executive order, which protected housing, education, credit, a whole wide variety of human rights. And that step forward is the Equality Act, which was introduced the other day in the House of Representatives. And of course, as usual, the problem will be the Senate. We'll see if we're able to get it through. We have been waiting for decades, since about 1973, for this to happen. Next. The problem, as usual, is the backlash. Now we're seeing anti-transgender proposals in many states, a couple hundred so far. Doctors and insurance companies and hospitals are refusing care to LGBTQ people based upon what's called religious liberty, which means that if they feel their religious rights have been somehow violated by an LGBT person wanting to have their picture taken for a wedding, that's the kind of thing that we're dealing with. And this could include discrimination against PrEP, which prevents transmission of HIV, hormone therapy, not allowing LGBT people to even be admitted to medical programs. 29 of these states don't have human rights protection except for Bostock and Obergefell. That's why we need the passage of the Equality Act. And I think that is the end of my presentation. Thank you.
Yes, thank you so much, Dr. Swan. Our next speaker is Paula Overby. And let's see.
Do I share my screen, or are you going to run it?
I will go ahead and run it. Just say next when you need the next slide.
All right, I'm Paula Overby. I was the first openly transgender woman to run for the U.S. House of Representatives. I've published my own book on the subject called The Transgender Myth. This is a lot of material in this. I'm going to cover it quickly. It's kind of about the future of healthcare. Go ahead, next. This statement from the Human Rights Campaign. Difficult to quantify the impact on the LGBT community. Part of that would be the fact that the definition of the transgender community has expanded rapidly, and the number of trans people identifying as transgender has grown exponentially over the past 10 years. In the UK has provided data that shows the number of girls referred to transgender services has increased 4,400% in the last 10 years. So some of the issues with data quantification. Next. So I've chosen to focus more general on marginalized communities and the large healthcare disparities that exist in the United States healthcare system. That includes LGBTQIA, Black, Latina, Latin, and Indigenous populations. This slide is from the CDC, emphasizes the socioeconomic conditions published by the Center for Disease Control that impacts health disparities. Discrimination, healthcare access, occupation, education, and housing. Next. The Navajo Nation is an example of a community that was severely impacted. This is a documentary that might be of interest to people. Next. This, of course, is Senator Bernie Sanders' favorite senator of the Medicare for All movement. Next. This lists some significant events in the evolution of America's healthcare system. The implementation of the employment-based model of healthcare is unique to the United States, and it is, by its very nature, extremely prejudicial, as marginalized communities have a difficult time reaching the levels of employment that provide that healthcare. And thus the desire to sustain that model of employer-based healthcare is really inherently racist. The HMO Act of 1973 was probably the beginning of our current for-profit healthcare system, and in a very real sense, the end of any notion of our healthcare system as an instrument of public health. The ACA was supposed to be a major step forward in expanding access to healthcare. It has been completely unsuccessful in controlling cost. In fact, it has resulted in massive infusions of government funds through reinsurance programs to help stabilize extreme premium increases that occurred after the implementation of the ACA. Next. Investor profits remain a significant part of the problem, but issues of complexity-driven administrative costs are also significant. Next. Should display these are the biggest HMO providers. HMO is health maintenance organizations, these providers, if you want to check on their profitability, it's extreme. Next. Some of the financial impacts of healthcare costs. Percentage of bankruptcies in the US due to medical debt, 66%. 75% of those people actually had health insurance. That bottom figure, 33%, is perhaps the most significant. That's fully one third of our healthcare dollars are not being spent on healthcare. Next. The drug companies and the insurance companies spend a huge amounts of money on publicity campaigns to convince the public that these costs are justified. They claim, drug companies, for example, claim that the high cost is based on research and development, but they spend $19 on marketing compared to $1 spent on R&D. I don't know if any of you are familiar with the number of drug ads we have in our media these days, but it's substantial. Go next. This is the kind of salaries the CEOs make for these companies. A lot of these are presumably nonprofit companies. Next. I think this slide pretty much speaks for itself. That little green line around the bottom, that's the number of physicians, growth in the number of physicians since 1970 up to 2000. I wish I had some more recent data on this, but you can see the extreme rise in administrative costs, beginning with the HMO, passing of the HMO Act in 1973. Next. More signs of healthcare crisis. I would emphasize the first two numbers here, the total number of hospitals. This severely impacts rural areas and the available hospital beds. These are numbers that really ought to indicate a decrease in healthcare costs. We have fewer hospitals, we have shorter hospital stays, we have more outpatient services, more or less, and oftentimes a lot of those outpatient services aren't covered by insurance. Next. This, yeah, go ahead. This is, illustrates the excessive rise of healthcare costs. I mean, they're skyrocketing healthcare costs. It's not a sustainable model. Let's see. Poor general health is a clear invitation to pandemics, and it's not surprising that the U.S. has some of the worst COVID outcomes in the world. Next. Just some more information on the ACA and the cost of it. I'm going to go on next. This is why I didn't want to use this PowerPoint.
Yeah, so I apologize for that. I was having issues opening up your file, so it.
Yeah, I sent you a new one last night, but that's all right. Let's see. So what the slide says is, these are kind of the industry, healthcare industry, media publicity campaigns. They talk about lifestyle. They say our people are old, excess use of healthcare, irresponsible people, new technology. Go on, next. But our population is not very old. We're not big smokers. We're at the bottom of the list on both of those metrics. Next. We don't use an excessive amount of healthcare. Again, we're at the bottom of the list for doctor visits. Go up next. And still, we spend nearly twice as much on average as most industrialized nations around the world. Go ahead. And we have worse outcomes. We have a lower life expectancy. Next. We have we have the highest maternal mortality rate in the world. Next. We have the highest infant mortality rate. There is a caveat here that the United States includes a greater number of premature births in these statistics, but that doesn't really account for the difference. Next. So this is one of the solutions that's being put forward as a single payer, Medicare for all, universal health care. It goes by different names. One of the things I find most exciting about the potential for universal health care is a return to the doctor-patient relationship rather than insurance companies controlling our options with little or no transparency or accountability. Next. Some states are taking action on their own. Montana has a model for state employees. Oklahoma and Connecticut removed private insurers from state Medicaid programs and saving like $2.25 billion. I'm with the health policy advocates in Minnesota. We have been working extensively for quite a number of years now just to get a simple audit of our HMOs. These are nonprofit organizations that have never been audited. We have no idea how they're spending our money. Next. This is a public option that the current administration has been talking about. It's really just another insurance program, probably going to have the same kind of impact that the ACA had in terms of funneling more tax dollars into the healthcare system without having any meaningful impact on the cost of healthcare. Next. Bernie Sanders isn't the only one pushing for Medicare for all. This is a bill introduced by Representative Premilia Jopal. This is the one that the healthcare advocates in Minnesota support. Next. So, there's a lot of benefits to a single payer system that apply to a lot of different groups. You can go next and it'll page through these. It'll display some of the items that appeal to various voter groups. Our current policy has evolved around protecting the profits of the healthcare industry, and that same policy perspective is clearly evident in the pandemic response. It's evident in the vast disparity in health outcomes and economic consequences for marginalized communities. There's been little or no discussion about the atrophy of our healthcare system. I refer back to the number of hospital closings, particularly in rural areas. There was neglect of our national reserves and exploitation of the essential worker class. I can recall saying a year ago, back in February of 2020, that once the virus touches the working class, it'll spread like wildfire because they are already health compromised. They don't have adequate health insurance. They are expected to come to work even if they are sick. They don't have sick days. So I think if we expect to do better in the next pandemic, we need to restore the resiliency of our healthcare system. This is an issue that should be extremely forefront and obvious in the midst of this pandemic, but it's not being really discussed. We need to increase the general health of our population. I, for one, don't wish to see the United States remain at the bottom of the list for global health outcomes, which is where we are today. Next. And who cares if you get sick? Nurses do. Some of this content was created by the Minnesota Nurses Association. This is a shout out to them and to all the nurses who risked so much and faced such enormous challenges during the pandemic. Nurses care for you. And our thanks to them for all they do. Next. I guess that's the end of my presentation. Thank you.
So thank you, Paula. We're going to go ahead and open up to a Q&A session for if anyone in the that is tuning in has questions for any of our panelists, please feel free to ask them. Your microphones are on mute, so if you would like to ask there, you can also post questions in the chat.
Christopher, I was going to mention, so you go ahead, please. You had a question. Ann?
Oh, hi, Wally. I think we met a while ago at a Walden faculty meeting.
Yeah, I recognize the name.
Well, it's good to see you. I am wondering do you know, where do students get the book that's not really expensive, the Rutledge book?
Oh, okay. You asked that question, so I ran to my shelf and picked out the book. If you got a pen,
I got the ISBN number.
you did get that. Okay.
Yeah, I found it. It's really expensive, and I don't know.
There's some discounted copies that I just saw. You can get an ebook, and there's the regular book. Amazon has it. Just go to Wallace Swan, Amazon, and then all my books will come up. There's like 6 or 7 of them. And
Okay.
So I went ahead and put the link to Rutledge's
Thank you.
website. So the hardback option is $250, but the ebook is $47.65, and you can
That's a rental, right?
Yeah, that's right. I think.
that's for the purchase. The 6-month rental is $26.48. The 12-month rental
Okay.
is $31.77. You can get it
Mhm.
on Amazon Kindle as well. So
Okay.
that's the link with all the information.
And
I
are
had
you,
some
are
students
you
that,
living in the Twin Cities?
pardon me?
Are you living in the Twin Cities?
No, I'm in Battle Creek, Michigan.
Oh, okay. Okay. I was
Yeah.
just gonna see where I could just loan you a copy. I've got about 8 of them sitting in my shelves.
Okay, well, thank you very much. This was a very interesting presentation. I have not partaken of the Michigan Capital Area chapter meetings. I might just have to show up more often.
We would love to
Yes.
have you.
We have a monthly board meeting, so we can send you that link, and send that
Yeah.
out to our membership so that you
Yeah,
are able to
and
join
go
us.
Western. It's nice to see a Bronco.
Thank you. So yeah, I'll actually be hopefully graduating by the end of June. I'll be defending my dissertation, and hopefully in April.
Wow,
So
that's great.
don't want to get a little presumptuous, but yeah, that's the
No.
plan. And so
Well,
I do want to make one point on Paula's presentation. There was the part about the tobacco usage and how that was going down. That's overall, but in terms of LGBTQ plus, I believe from my presentation it was 37 to 27. So still disproportionate number of LGBTQ plus are smokers, and that
Yeah.
exposes us to a more severe case of COVID-19.
Right.
So it looks like Dr. Bagdasarian had to leave for the day. So if there's any questions for her, I believe she's on Twitter or, but yes, she had to leave for another appointment, but she just came to present on COVID-19 and kind of a general presentation on that. Myself, Dr. Swan, and Paula focus more on the LGBTQ plus side. She focuses more on marginalized populations in terms of race, ethnicity. So do we have any questions from anyone that has tuned in?
I saw one that just ended up on the chat. Can you take a look at that, Christopher?
Oh, yes. Yes, so all the slides will be available at aspamycap.org. The link is up here. It'll be on our special page, aspamycap.org/LGBTQ. So the event page will be converted over to a video page. It'll have the video from Cisco WebEx and those slides will be available, and you'll be able to download the presentation as well. And then we'll also put a link up for the Rutledge Handbook of LGBTQIA Administration and Policy. And then the next question, would mobile vaccination units or drive-in sites be helpful to the LGBTQ community? Some are now being developed for users in certain groups.
Well, anything that gets the vaccination, I mean, we're at, I believe, 13% nationally. Anything that can broaden the distribution would help. And I also want to mention the concern I have. I've been watching the B117 mutation, for United Kingdom, and also the one that we have from Brazil here in the state of Minnesota. And in the last week, the number of cases of the B117 in Minnesota have gone from 18 to 40, so it's over doubled. And typically, our detection is related to people going in for a test, and that's usually 10% of the total. So we may have as many as 180 up to 400 of those cases floating around in our metro area, which is where they're concentrated. And of course, our state and many states around the country have been loosening restrictions. And I just looked at the news, especially restaurants and bars, and several of our LGBT bars are like great resources for transmission of COVID. We just open them up again. Same with restaurants, same with the gyms. And we're talking now about opening up the stadium so we can have a baseball game. So,
Walt, your microphone is extremely garbled.
I'm sorry.
Can anyone else understand what he's saying?
Yes.
Yeah.
Okay, is it just me that's, sorry.
Be closer, but I still understood what he was saying.
No, just kidding. What I'm saying is,
That's better.
with the possibility of mutations, that Dr. Osterholm has been pushing this very hard, that we're going to have a dramatic increase in what we're doing is we're opening up all kinds of facilities like bars and restaurants and gyms and everything else, which is exactly the wrong thing to be doing at this point in time, I think.
Yeah, I share that concern too, is that until we get more of the vaccines out, maybe we shouldn't be opening up things quite as quickly as what we are. There's this feeling of going back to normal, and I think that's a false hope at this point.
I also want to add that the social isolation component is particularly important in terms of the LGBTQ plus community. So our LGBTQ community centers are essentially shut down. They're doing these meetings like this, and those are oftentimes the only therapist or kind of social interaction that many people have with the whole community. And then on top of that, the gay bars, in terms of vaccinating the LGBTQ community, that's one of the ways to reach people, but those bars are closed. There's a few other ways to interact with the community, but of course the Pride festivals are not happening. So what happens is, and this is in the McKay 2020 source, focusing on how LGBTQ plus behaviors have changed in terms of seeking out partners and sexual behaviors, how those have changed, but then also the LGBTQ community may not comply with a lot of these mask mandates and or social distancing. At least they may comply with the mask mandates, but not the social distancing, in order to meet people to kind of deal with that social isolation. That a lot of it comes from the religious isolation, being kicked out of churches and So that is a very strong component that is a driver for COVID spread in our community.
I would also add that this is somewhat symptomatic of our lack of universal health care. There's been a lot of good confusion over billing practices. We essentially have to provide free services that wouldn't normally be free, right? That people can't simply go to their normal channels, their clinics and pharmacies. And so we've had to develop a lot of new infrastructure to manage these vaccine distribution programs. The same thing happened in testing, right? It took forever to develop our testing capabilities for the same reasons. We had to develop all of this new infrastructure. So, and even today, depending on where you go, the shot isn't necessarily free. Clinics and hospitals and facilities can still bill for administering the vaccine, even if the vaccine is at no cost. So those are all factors of our healthcare system.
And then also in terms of the United States, in most places, the number of COVID cases are declining. Internationally, North and Eastern Europe, a lot of the Slavic countries like Serbia, they are experiencing an uptick now in COVID cases. But whereas our cases went from 300,000 a day, now we're down to 50 to 60,000 a day here in the United States. So geographically, there's in terms of geography, different parts of the world where the virus is on the upswing. And a lot of these countries, they also have very unfriendly policies towards the LGBTQ plus community. Russia, it's on the rise in Russia as well. So yeah, Sweden is the North European country that is on the rise in terms of the cases.
Christopher, I wanted to mention a couple of things that are kind of upcoming. We're going to be taping the National Public Administration Society presentation next Monday. And what I found in one of them, the case of Alaska, essentially the effect of COVID-19 on the LGBTQ community there is that they closed all the community centers. They've closed, all of the ways that people interact, and I was just struck by how destructive it has been on the community organizations. So we're going to have Denise Sedgwick talking about Alaska at the ASPA conference in April. And another speaker, Adrian Schenker, is going to be talking about the problems of counting LGBT people as part of the response to COVID-19. We have so few states that are collecting information, and most of them aren't. That is an issue, and he's got a presentation that's going to be at the ASPA conference that's being taped next Monday. And my final point is essential workers, I think, should be prioritized in the queue, and they aren't. They are, the Hormel plant, all of the different meat processing plants that we've seen with a lot of spread of COVID-19, those are not prioritized. And I think that's a serious deficiency of our current system.
And then also, in addition to our taping for our ASPA conference presentation on April 6th, we're doing a presentation with the DSJ, the Social Justice, Democracy and Social Justice section of ASPA. And then we're also working on a career connections group. Did you want to talk about that, Wally?
Yeah, because of the fact that our community has been disproportionately affected by loss of jobs, a couple of us, including Christopher and Jose Izarri, and one other person, we've gotten together and put together something called Career Connections, which we hope will be a subcommittee of the LGBT section of ASPA, so that people who are applying for jobs and are LGBT will find out how to write the best kinds of resumes and do interviews and techniques for networking and so on, both for academic people as well as practitioners, because we see a need there, and we've got several of us have been working on that. We're going to hopefully get approval by the ASPA section for us to be a committee of that group.
Great. Thank you for that additional information on the group. And then also, just really quick, we're going to wrap it up soon, but I do want to say that given the decline in COVID cases, I do kind of have a theory or of why that may be taking place, why there is the decline. They've been trying to figure this out, and why this decline is happening. There's not like a one particular cause. One of the things is we have very cold temperatures, so people are not, people are more likely to distance and stay inside, and just given the temperatures and especially in Texas, with the crisis there. And then also we have about 63 or 65 million that have already vaccinated. So when you look at, say you have people in a grocery store and one person out of 30 people have COVID-19. Well, if you've got, 12 of those that have been vaccinated, you have a much smaller pool to where that can spread, and then they still have to come in contact. So you really, so you may have a reduction of, like, children aren't very good at spreading the virus, and they don't typically have very severe symptoms. They have very strong immune systems. So you look at, maybe 160 million or so adults that could spread it, and if you've had 65 million of them vaccinated, you have a much smaller pool that can, spread that to. If you look at each person as a node, and spreading that to multiple nodes, and you're not able to spread that virus as effectively when you have all these people that have been vaccinated. And then our guards are up as well, so we're all masking. There's a little bit of pandemic fatigue, but
So
our guards are up.
I want to respond to that because I work in a school, all right, and those numbers were dropping precipitously long before the vaccinations program was implemented. We were already planning for school reopenings based on the projections of those numbers back in January.
And then also about a week or so after,
it's a complex issue, right?
there's multiple reasons for why that, the decline is happening, but also the January 6th situation on the crisis in Washington, D.C. that really kind of opened up people's eyes to, the administration, to Trump. And, he was very tone deaf during the campaign. He wasn't wearing masks. He got he got COVID, allegedly. And people weren't wearing masks. They were being, it was mask defiance. And once people were, his support has been steadily dropping. So his decline in support has possibly influenced the number of people that are, wearing masks and distancing, and over time, that political, the decline of his political capital.
Christopher, I'm going to throw in some other ideas for that. One is Michael Osterholm had several different charts showing what he saw as the projections for this epidemic. And one of them goes like this. It's like a roller coaster, up and down, up and down. And when you go up, everybody starts to panic and they start wearing their masks and so on. And when it goes down, everybody says, oh, it must be solved. And so they stop doing what they're supposed to be doing to protect themselves. And I think that plus the big spike this last time was holidays, Thanksgiving and Christmas and travel. And now we're seeing everybody going back to work and not traveling, and suddenly it goes down. I think it has a lot to do with that. And I would add that the Dr. Fauci has said you have no idea yet whether the effect of vaccinations is really in play or not. We're only at 13%. And that's maybe reducing a little bit, but he says there's no data to support that. So I think we have to be careful about our estimate.
So when I was talking to Dr. Bagdasarian on the phone yesterday, as you were talking about the cresting and the trough of the and how the case for a while the cases were it was going over that crest and then it was dipping down and then it was going up higher. So it was going up. The slope was the slope is now downward. It's not able to spread as effectively given not only the climate, but people are on guard with, masking, distancing, all of that. There is a little bit of fatigue, as I mentioned. But then also Dr. Bagdasarian was saying that there's a score that I don't remember exactly what she said, but it was like a score that they
It's the R score, it's that roll thing.
once it gets below 1.0.
1 point, there you go. That's what it is. Yeah.
So now that and just today we had when the vaccine when they first released the results of the trials, the studies, that was one big turning point in the virus. The second big turning point was January when we started really ramping up production with the Defense Production Act. The next turning point just happened today, and that is the Johnson & Johnson vaccine is now a third suitable candidate. It is a one-shot vaccine, and it reduces severe cases and hospitalizations by 86%.
Well, I think if we're going to speculate about public policy, we ought to have some data and charts available to look at, because I don't agree that the numbers are tracking the way these events. We closed our school well ahead of the holiday travel period because numbers were skyrocketing back in late October, mid-October, way ahead of the travel season that was supposedly creating this huge spike. So, I'd like to see the graphs and the data if we're going to speculate about public policy and the nature and effects.
That's why I mentioned Fauci, because he says we don't have any evidence of any of this yet to know what was going on. So maybe we should change another.
So yeah, in terms of the evidence for, I am speculating a bit based on some of the events that like the experts have said on in epidemiology. I am speculating a little bit on that, but definitive proof today in terms of the New York Times article that came out, 86% reduction in hospitalizations, severe cases. So I think that's a big moment in towards the end of this pandemic.
Okay. Have we got any other questions for people?
I think we're kind of winding things down. It's 1:30 Eastern time, and we just have board members and panelists left. So thank you everyone for presenting today and speaking to us here at the ASPA Michigan Capital Area Chapter.
Thank you, Chris, for organizing all this and getting it together and presenting it. You did a great job. Thank you.
And I'll see you guys next week for the ASPA conference recording.
Okay, thank you, Chris.
Have a great day. Bye,
Thanks.
everybody.
Bye.
Bye.